You can have a viva table like this, and the examiner can ask you, what do you think about this X-ray? We know that it is non-union, but we should be describing what we are seeing. I see the lateral view of the right femur with an antegrade intramedullary nail used to fix a diaphyseal fracture. What concerns me is the atrophic non-union, and you can ask for other views. Here, the biological process of fracture healing has come to a standstill, and causes of non-union are multiple, and my management will be based on the causes, which I divide into infection, local causes, systemic causes, and mechanical. So any non-union is infected unless proved otherwise. I would assume that there is no history of events suggestive of infection, and there are no sinuses or wounds healed by secondary invention. Even in the absence of these findings, I would exclude infection by blood markers and culture of tissue samples next to the bone. MRA or leukocyte scan are useful adjuvants. MRA is more sensitive but less specific. Leukocyte scan is good for active infection, but in chronic rumbling infections they are of less use. And we have to be ready with the Cerny and Mutter classification. We have got the anatomical type, physiological class, and the factors affecting the physiological class. The anatomical classes include medullary, superficial, localized, and diffuse. And the physiological class will be of interest to your examiner. And we should be ready with the different physiological classes when asked for. And A means good immune system and delivery. B means compromised locally or systemically. C means requires suppression or no treatment. The treatment result will be worse than disease. We have to remember this. And the factors affecting the physiological classes include systemic factors and local factors. Important systemic factors include malnutrition, renal or liver failure, alcohol abuse, immune deficiency conditions, etc. The local factors include chronic lymphedema, venous stasis, major vessel compromise, arteritis, extensive scarring, and radiation fibrosis. The local factors include mainly the index injury and the surgical technique. The index injury means the fracture personality. When we move from Castello 1 to 3, we are moving from a less probable chance of non-union to a more probable chance of non-union. And open fractures have got more chance of going in for non-union. Compartment syndrome can lead on to non-unions. Soft tissue injuries, if the patient is having compartment syndrome or type C Cerny soft tissue injury, the chance of non-union is small. The surgical technique is also important. How the surgeon is handling the tissues, use of tourniquet, wound coverage, the approach, the distraction at the fracture site, the use of reamers, appropriate application of fixator or the cast. All these can affect union, and if not properly done, can lead on to non-unions. The systemic factors include patient comorbidities like diabetes, COPD, PVD, steroids, endocrinopathies, vitamin D and K deficiency. Social factors include alcohol, smoking, and non-compliance to treatment regimes. The mechanical factors include what principle was applied, was it appropriately applied, was it appropriate for the situation, and have the surgeon achieved the intended result, and how stable the construct is. When we go on to management, we have to acknowledge the fact that this is a difficult problem. We have to assess the causes and address the causes, and we require multidisciplinary team approach, and we have to confer with the colleagues with more expertise, Having said that, the goals will be to achieve union, eradicate any infection, address shortening or malalignment, and achieve good function. Management plan again depends upon the host type, soft tissue status and coordination with the plastic surgeon, and bond factors such as shortening, alignment, bond loss, joint stiffness, etc. If the patient is having a septic non-union, the preferred technique is a three-stage procedure. The first stage is to remove the implant, resect the devitalized bone and the soft tissue, give local or systemic antibiotics. Temporizing external fixator has to be applied, and the serial blood markers, blood culture, and repeated debridement, if any, dictate the further course of action. VAC is a useful adjunct. The second stage includes soft tissue coverage by the plastic surgeon. Third stage includes the definitive procedure such as nailing, plating, or circular frame. If the patient is having a hypertrophic non-union without any previous surgery, if it is in good alignment and no shortening or gap is present, a functional cast or a low intensity with or without low intensity pulse ultrasound may be tried. And nailing or plating can give more stability and can be useful. The patient is having an atrophic non-union with previous surgery. If there is associated gap, shortening, and malalignment, the treatment of choice is circular frame. If the patient has had a previous surgery and there is no infection, single stage revision fixation with graft or bone morphogenic protein after actively ruling out infection is the treatment of choice. If we go back to the previous slide, most important thing in your viva is to diffuse the question. If you structure your answer like this, that is, the causes of non-union are multiple and my management will be based on causes which I divide into infection, local causes, systemic causes, and mechanical causes, then the further answering of the viva will be easier.